Today, we are going to look at a valvular abnormality of the mitral valve, which is mitral stenosis. We are going to discuss this topic in this brief outline, starting with the anatomy, etiology, pathophysiology or hemodynamics, clinical features, evaluation, and management. So let's look at the brief anatomy. So here you can see this is the anterior leaflet, and here is the posterior leaflet, and between these two leaflets we have the commissures, the medial commissure and the lateral commissure. And these are the fibrous strands, the chordate tendineae, which are supporting these leaflets. And at the bottom, these chordate tendineae are attached to these papillary muscles. So we have a medial papillary muscle and the lateral papillary muscle. And the same, this is a diagrammatic representation. As you can see, here is a real image where you can appreciate the anterior leaflet and the posterior leaflet and the commissures. And in the bottom, the image that you can see is of a fibrotic valve, or you can see that the valves are thickened and fibrosed, because of which there is mitral stenosis here. Now let's start with the etiology of the mitral valve. The most common culprit behind the mitral stenosis is rheumatic heart disease. Then comes congenital mitral stenosis. There is also atrial myxoma, and connective tissue disorders like rheumatoid arthritis and SLE can also cause mitral stenosis. So when you look at the mitral valve area, the normal mitral valve area is 4 to 6 centimeters square or square centimeters. When this mitral stenosis starts developing, in progressive mitral stenosis, the diameter is usually more than 1.5 square centimeters. In severe MS, you call it as a severe MS when the valve diameter is less than 1.5 centimeter square, and you call it as very severe mitral stenosis when the valve area is less than 1 centimeter square. Now let's look at the pathophysiology or hemodynamics of mitral stenosis. The primary problem is there at the mitral valve. Here is the mitral stenosis, and when the mitral valve is stenosed, the blood flow from the left atrium into the left ventricle is obstructed or slowed down because of this stenosis, and the blood flow from left atrium into the left ventricle happens during the diastole, and hence there is a diastolic murmur. A mid-diastolic murmur is heard. And when the blood emptying from left atrium into the left ventricle is obstructed, there is a buildup of pressure in the left atrium, and with elevated left atrial pressure, there is left atrial enlargement, and left atrial enlargement further results in atrial fibrillation, and fibrillating left atrium will eventually result in stasis, and stasis of blood in the left atrium predisposes to develop thrombosis, and the thrombosis can result in embolism of that thrombus, and that can result in stroke. On the other hand, it can also cause some compressive symptoms when it compresses on the recurrent laryngeal nerve that can result in hoarseness of voice. Now, further, the back pressure pools up into the pulmonary venous system, and that will result in pulmonary venous congestion, and congestion of the lungs can result in dyspnea, repeated pulmonary tract or respiratory tract infections like bronchitis or pneumonia, and then because of the rupture of the bronchial and pulmonary venous connections, that can result in hemoptysis. So all these are the consequences of mitral stenosis. And when you go back further, there is buildup of pressure in the pulmonary artery as well. There is pulmonary arterial hypertension, and because of that there is development of pulmonary regurgitation. And further, when there is so much pressure, so much obstruction during along the outflow tract of the right ventricle, so the right ventricle will also pump harder, and there is right ventricular hypertrophy, and eventual back pressure will result in tricuspid regurgitation, right atrial enlargement because of increased right atrial pressure as well, that is visual in the form of elevated JVP in the neck veins. And because the atrial contraction is significantly affected, there is giant A wave in mitral stenosis. And of course, because of this chronic congestion of the right heart, there is also development of congestive hepatomegaly, pedal edema, and all the features of right heart failure. Now let's look at the clinical features. Usually, it takes at least 20 years for the patient to develop symptoms of mitral stenosis when you look at the onset of rheumatic carditis. So, between the rheumatic carditis and to the development of symptoms, it takes at least 20 years for the development of symptoms in the case of mitral stenosis. The most common presentation is exertional dyspnea and fatigue. Like we already saw, since the mitral stenosis is not allowing the blood from left atrium into the left ventricle, there is pull-up of blood and there is pulmonary congestion, that is because that will result in exertional dyspnea and fatigue. The infective endocarditis is also there, which is again less common here. And the left ventricle is unaffected. As you can see, the left ventricle receives less blood, and there is no significant pressure hypertrophy, pressure overload, or volume overload on the left ventricle, and the cardiac output is relatively preserved till late in the disease. What are the complications? So the atrial fibrillation, because of the unrelenting left atrial pressure, can result in left atrial enlargement and atrial fibrillation that can eventually progress to development of thrombus, embolization, and stroke. Recurrent bronchitis or pneumonia because of the pulmonary venous congestion, and hemoptysis because of the pulmonary venous congestion and rupture of the bronchial and pulmonary venous connections. Now, what you can see in the image is a purplish rash over the malar areas. That is nothing but a malar flush that you commonly see in mitral stenosis. On examination, the mitral flush is seen, and when we talk about the vital examination, the pulse is usually low volume and the blood pressure is usually normal. But in very severe mitral stenosis, where the flow of blood from left atrium into the left ventricle is significantly reduced, that's when the cardiac output will also be reduced. When the cardiac output is reduced, systolic blood pressure is reduced. When the systolic blood pressure is reduced, so systolic minus diastolic blood pressure, that is pulse pressure, is also narrowed. So there is narrowed pulse pressure in severe mitral stenosis. Jugular venous pressure is elevated with a prominent A wave because of this pulmonary arterial hypertension. When the patient develops tricuspid regurgitation, then V wave can become prominent. Then parasternal lift or heave can be seen because of right ventricular hypertrophy or the left atrial enlargement. Of course, both of them can be seen in this mitral stenosis. Parasternal heave means on the left parasternal area, when you keep a hand here, or even when you keep a pen with, when you observe the pointed tip, you can appreciate the parasternal lift that is happening because of left atrial enlargement or right ventricular hypertrophy. And when you look at the heart sounds, because of this fibrosed mitral valve, the S1 is quite loud in initial part, and it becomes soft because of calcification. So when the patient develops a severe MS and the mitral valve becomes calcified, the loud S1 becomes very soft. And S2 is loud because when the patient develops a pulmonary arterial hypertension with PAH, there is loud P2. And because of pulmonary arterial hypertension, the P2 also is delayed. A2 is actually followed by P2, but P2 is delayed, and this delaying of P2 will result in the gap between A2 and P2 that will result in a wide split S2, and you can also see there is delayed P2. S3 and S4 are not commonly seen. S3 is seen when there is volume overload of the ventricle, and S4 is seen when there is a stiff non-compliant ventricle. Both of them are not seen here, so S3 and S4 are less common. But when the patient has significant right ventricular hypertrophy, RV-S4 may be rarely seen. An opening snap at apex may be seen. The opening snap is nothing but a snapping sound that is heard with the opening of the mitral valve. Usually in a normal patient, opening of valves does not make any sound, but in this mitral stenosis here, the sudden opening of the mitral valve with the buildup of pressure in the left atrium can generate this opening snap. Now, in the top, you can see there is S1 and S2. The phase of cardiac cycle between S1 and S2 is systole, and the phase of cardiac cycle between S2 and S1 is diastole. Now there is the S1 which has become loud now, and P2 which has become loud because of pulmonary arterial hypertension, and it is also delayed. So there is a wide split S2. And there is development of an opening snap because of this fibrosis of the mitral valve, and sudden opening with left atrial pressure can result in this opening snap. And soon after there is opening of the mitral valve, sudden gush of blood from left atrium into the left ventricle can generate a decrescendo murmur in the mid diastole. It is a mid diastolic murmur with a decrescendo configuration. And the terminal part of diastole will also generate a murmur because of the atrial systole. Initially, there is rapid filling because of negative pressure in the left ventricle, but at the end of the diastole, the left atrial systole, the atrial contraction will give out again increased flow of blood from the left atrium into the left ventricle that is responsible for this pre-systolic accentuation of this murmur. The gap between A2 and OS will help in determination of the severity of mitral stenosis. More is the duration of the murmur, more is the severity of mitral stenosis, and less is the A2 OS gap, more is the severity of mitral stenosis. Now let's describe the murmur. The murmur in mitral stenosis is a low-pitched, rough, rumbling mid-diastolic murmur of decrescendo configuration. It also has this presystolic accentuation with the opening snap. It is heard at the apex, better heard in the left lateral position at the end of expiration, and there is no radiation heard. duration of murmur increases with severity of mitral stenosis, and S2 opening snap gap shortens with increasing severity of the mitral stenosis. This is what is the description of murmur in mitral stenosis. Now, there are some more murmurs that are heard. As you can see, along the backward flow, there is development of tricuspid regurgitation and pulmonary regurgitation. They can also generate some murmurs. So, the tricuspid regurgitation can generate a pansystolic murmur, and it is heard at the lower left sternal border. So, the right-sided murmurs are usually better heard at the end of inspiration. This is also better heard at the end of inspiration. This is called as the Carvalho's sign. And the pulmonary regurgitation can generate an early diastolic murmur. It is heard at the left upper sternal border, and this is called as the Graham-Steele's murmur. So a murmur that is heard at the lower left sternal border, that is at the tricuspid area, and the murmur accentuates with inspiration, is the tricuspid regurgitation murmur. And a murmur which is heard at the upper left sternal area, which is because of the pulmonary regurgitation murmur, and it is called as the Graham-Steele murmur. Now let's look at the further evaluation. So when you look at an ECG, you can appreciate P mitral. P mitral is the left atrial enlargement, also called as the P mitral, and you can also appreciate right ventricular hypertrophy or atrial fibrillation in cases of large left atrium. And when you look at the chest X-ray, there is a straightening of the left heart border, and sometimes double density sign can also be heard. I'll show you the images in the next subsequent slide. And when you look at a 2D echo, initially the transthoracic echocardiography is the one that is done. But if you want to look at the left atrial thrombus, then transesophageal echocardiography should be done. So if the transesophageal echocardiography shows the left atrial thrombus, then do percutaneous balloon mitral commissurotomy after 3 weeks of anticoagulation. So 3 weeks of anticoagulation should be given to the patient if the patient is having a thrombus in the left atrium. So the first image on the left side is a normal image, as you can see, and when you compare it with when you compare the right one with the left one, you can see there is cardiomegaly, increased cardiothoracic ratio, and here is the normal. There is a concavity in the area of the left atrium here, but here the left heart border is straightened out. This straightening of the left heart border is seen in this mitral stenosis because of left atrial enlargement. What you can see in this image is a double density sign. You can see here is the right atrial margin and here is the left atrial margin. Both the atria are overlapping one against each other. That is why two densities can be seen distinctly. See here, this is called as the double density sign because of enlargement of the left atrium. Now let's talk about the treatment. So treatment includes the medical management, management with intervention, as well as management with surgery. So medical management is given alone only when the patient is having mild MS and if the patient is asymptomatic. What medical management that you can give? You can give diuretics because you want to relieve the congestion inside the lungs. And anticoagulation can be given with the vitamin K antagonists like warfarin in a case of mitral stenosis when the patient is also having atrial fibrillation, because atrial fibrillation increases the risk of thrombus in the left atrium, which can further embolize and can result in stroke. Now then come to the interventional part. We have the percutaneous balloon mitral commissurotomy. In this procedure, you introduce a catheter through the femoral vein, go into the heart, go across the interatrial septum and enter into the left atrium and insert the balloon into the mitral valve and you inflate the balloon. That is called as by inflating the balloon, you are dilating the mitral valve. That is nothing but the procedure here. And what are the indications? The indications to do the percutaneous balloon mitral commissurotomy is starting with number one, if the patient is symptomatic plus severe MS. Severe MS means on doing an echocardiography, you can appreciate the mitral valve area. If the area is less than 1.5 centimeter square, then it is an indication to undergo PBMC. If the patient is asymptomatic and if the patient is having severe MS, if the patient is having new onset AF, if the patient is asymptomatic with severe MS, if the patient is having new onset atrial fibrillation, and that is an indication. If the patient is asymptomatic and severe MS, and if the patient is having pulmonary arterial systolic pressure more than 50 millimeters of mercury, again it is also an indication. And lastly, if the patient is asymptomatic but with very severe MS, that is the mitral valve area is less than 1 centimeter square or 1 square centimeter, is an indication to undergo percutaneous balloon mitral commissurotomy. So these are the indications for the patient to undergo PBMC. And for the patient to undergo PBMC, there should not be any moderate MR. Okay, so if because when you inflate the balloon in the mitral valve, that can itself can result in mitral regurgitation. Sometimes the mitral regurgitation itself can be a complication of this balloon based mitral commissurotomy. So there should not be any MR prior, and there should not be any left atrial thrombus. So no left atrial thrombus, and the valve morphology should also be favorable for the patient to undergo this interventional procedure. So the complication is mitral regurgitation, because excessive dilatation of the balloon can result in permanent dilatation of the mitral valve. Then comes the surgical modality, which is mitral valve surgery. Using surgery as well, you can do commissurotomy as well as mitral valve replacement. So if there is a favorable mitral valve morphology, you can do mitral valve commissurotomy. And if there is valvular thickening and fibrosis, you should undergo mitral valve replacement. In a patient of mitral stenosis with pulmonary arterial hypertension and tricuspid regurgitation, or in a patient of MS along with coexistent mitral regurgitation, again mitral valve replacement is the best modality. Or if the patient has already undergone percutaneous balloon mitral commissurotomy, if it is failed and again the patient has come to you with the similar complaints, then you can do mitral valve replacement. Failed PBMC is also an indication to undergo mitral valve replacement. So these are the indications for mitral valve surgery. So this is all about the mitral stenosis that you need to learn for the entrance examination. Hope you understood this. If you like this video, please share and subscribe to this channel. Thank you.